hope that you all feel a little bit refreshed after some coffee and biscuits, and hopefully you're all in a little bit of a better mood to be receptive to what we're talking about. So I'm going to talk to you about focused care. There's been some mentions in previous talks just about focused care practitioners, and some of you have focused care in your practices. We've worked with you for years, and you'll know exactly what we are, where we've come from. Other people may have never heard of focused care, and so this is just a little bit of a background for you of what we are, where we've come from, and hopefully where we're going as well. Might help if I actually knew how to use the pointer. Oh, there we go. So also, Laura said in her early talk that you can heckle. Please don't heckle, that'll actually really put me off. So please be well behaved. So focused care, we look at poverty, complexity and engagement, and that intertwined is what we look to deal with and to be part of that intertwinedness and unpick it hopefully for some of the people that we work with. So this is a beautiful picture of Oldham where it all started, and you can see the lovely hills in the background and quite a nice place to work. The reality was a very grey porter cabin that looks a little bit different. So Hope Citadel was in primary care, and focused care all started in primary care. I would just like to point out, when I saw this picture, I don't know how well you can see, but Laura is in that picture of people of the original group of the setup, and those pink tights are pretty impressive, Laura. So, in this picture of lots of snowmen, there is a panda somewhere. It's really, really difficult to spot, and our strapline for focused care is making the invisible visible. Once you spot that panda, it's really, really hard to unsee it. And so the GPs that were working in primary care in Oldham, they read papers, they saw all of the documents that said there is health inequalities in our area, but they couldn't see it, they couldn't access it. And that was where focused care was born, that they said, right, we need to do something to address this. Let's create something. And made their first focused care worker. Once they saw it, you cannot unsee it. So I don't know who's found it, but at the bottom, the panda is sat kind of on that bottom line. And once you've seen it, you literally look at it and you're just like, oh God, how did we not see that before? And that is what we're now seeing with focused care. You know, the growth that we've seen in the individuals that we're working with, it makes you think, how did we not ever see that that was there, and how could we ever not work with those individuals? So the typical focused care patient that we look for are the people that keep you awake at night. When you leave practice or you go home after your day's work and you just think, I really don't think I helped that person enough. I'm really worried about them. I don't know who to signpost them to. I don't know how I can help engage them better. Those are the people that we want to try and make you feel better about, that somebody is helping them. People with multiple complex problems. So it's not a case of they come to you with the one issue, like there was some talk earlier about they come with a list of 6 issues. They will often be a mix of medical and social. And if you look at just one of those in isolation, so you just deal with the medical issues or you just deal with the social issues, then you'll never achieve decent progress with that individual. So multiple complexity, often really chaotic individuals or families. The ones that are over-attending primary and secondary care, so the ones that are calling every day, they're coming in multiple times a week, and no matter what you do, no matter who they speak to, no matter who you refer them to, you are just not sorting their problems for them, and you're not making their lives better. And then the flip side, so making the invisible visible, that disengagement. They might be registered on your GP surgery. You might even know that they have multiple complex health issues, comorbidities. They're on your QOF register, but you never see them. You might send letters out. They'll never come in. They're the ones that Laura scoops up every year when she goes door knocking, but you just can't access them. Or you make a referral for them that they've actually kind of come to a surgery and said, I've got this issue. You make that referral, but they never engage in that service, and you don't know what reasons are behind that. So that is our typical patient that we aim for. We pick the most complicated. So this is the FitBus model. So it looks at what health inequalities are and breaks that down, and it uses a term that's coined in paediatrics, so failure to thrive. If you've got an infant that's small, they're not gaining weight, they're not achieving their milestones, they're classed as failure to thrive. And when you translate that to adults in our community, we see lots of adults that are failure to thrive. They're not achieving in life with multiple issues. And that failure to thrive is multiplied by their barriers to universal services. So there might be universal services that are in place in their area and mainstream healthcare, but for one reason or another, they have barriers that are blocking their access to it. And then that's just exacerbated by the social determinants that they face on a day-to-day basis. So that is our Fit Bus. So what we do with people that are experiencing this failure to thrive, we go out and we find them. We again look for the most difficult and we want to make them visible. We want to spend more time with them than the time that a GP has, because that 10 to 13 minutes that you get, we want to be able to engage with them over a long period of time and work through with them in that change. So passion led us all here. I think that any focused care practitioner or anyone that works with focused care has a massive, massive passion. And probably everybody in this room has that passion as well, because otherwise you wouldn't be here. Let's face it, it's much easier to work in leafy suburbs where you've got more opportunities and people engage. But what you get reward from the people that you work with and the individuals that we deal with focused care drives our passion to carry on working with them. So we work in, Laura had this slide up before, we work in the bottom 20% of deprivation in general. So looking at the deprivation score of a 1 or a 2. The really interesting surgeries are sometimes surgeries that might be a 4 or a 5 on the deprivation score. And that's because they're massively skewed by areas around them. So we've had inquiries from surgeries, and when you look on the data, the government data says that they're in an area of or half a mile away is a 7 or an 8, but their tiny little pocket that they're sat in the middle is a 2. And so the services that are around those areas are actually almost much worse than an area of wide deprivation. So they're really, really interesting pockets to look at as well. So we look to work with the most vulnerable in the most deprived, and we highlight that gap between the social and the medical. We are a complementary role. We don't want to replace existing roles. If something is being done and it's being done well, then fantastic. We don't want to replace things. We want to add to them, and we want to make things better. So focused care sits alongside a number of other roles. They work within the multidisciplinary team and they work within their GP practices, and they're really, really integrated in the practices as well. We found from the very early days that the bottom 20% of deprivation actually financially and time-wise takes up 80% of your time and your finances. So if you invest well and you invest early in that bottom 20%, the change can be massive to see. And our focused care practitioners know their areas really well. They know their communities well. They know their GPs well. They know their services. And that's really, really important as well. So when our initial focused care worker went out and we started doing initial assessments with people, these were the key themes that we found. Often there were a number of themes that came up. It wasn't just one of them. If it was one of them and an individual engaged in, say, a referral to a smoking cessation clinic, fantastic. If they've got a number of those, you already start to just build those barriers to be able to engage, and they might not take up that option of a referral to one service. We see these themes over and over again. They're very, very common in amongst all of the people that we deal with. The outcomes that we've seen from working with individuals in focused care have been phenomenal. Like Laura said, when you look at the data, it is unbelievable, the change that people can make. And if you really engage somebody and you work with them at that level of complexity, they often do want to change, and we involve them in that model of change that they're willing to make for themselves. So you see improved mental health, reduced PHQ-9 scores, reduced debt or a debt management plan in place that they feel more able to deal with. benefits issues are sorted, so they get a further entitlement to benefits, or they don't have any concerns about their benefits going forward. New tenancies that are supported, or families that are coming out of temporary accommodation and they're more stable and they've got a base for their family that they can start to build on and grow. People that were previously unemployed have returned to employment, and the reduced risk of physical abuse. And then health outcomes, you see reduction in alcohol, reduction in stimulants, opioids, cannabis use, reduction in or completely stopping smoking, and then the uptake in the screening programs that are national, that previously they wouldn't have engaged with potentially. They've got trust in that professional, they've got trust in a focused care worker that then builds them back into the mainstream system and says, come on, let's go to the GP, let's get you screening, because that's really important as well. Yes, we've dealt with your mental health issues, yes, we've looked at your housing, yes, we've looked at the fact that you've not had electricity for the last 3 months, and you're moving forward and you're progressing. What's really important is we look at the future and we look at your health and make sure that you're in the best health possible. So let's go and have your bowel screening. So there is a case study for a patient that had uncontrolled diabetes and schizophrenia, was very, very socially isolated, not integrated within the community, and had missed a number of healthcare appointments. Had a really poor diet, heavy smoker, heavy intake of alcohol, and often didn't take his schizophrenia medications regularly either. So he was referred by GP to a focused care practitioner, and they started to work with him. He'd missed a endoscopy appointment that was really important for him to go to, but he hadn't gone because he couldn't cope without drinking alcohol. So they arranged the appointment for early in the morning. The practitioner went along with him, and he went to that appointment. And just from that initial appointment, that started to build trust, and then worked with the practitioner to say, actually, I will look at my mental health issues, and I probably do understand that it's important to look at that. And the focused care practitioner helped him access counselling services to help with his schizophrenia. And that was quite an interesting relationship that they built, that then they could start to look at the other health implications, so looking at the long-term management of the diabetes as well. So who are these wonderful people that we get to do this job? They are a very special cohort of people, and they have common themes. They're a little bit nosy, they're very, very kind, and they are very determined, and they've all got a really, really strong sense of social justice. They want to make a difference, and they want to see a difference in individuals' lives, and they will work tirelessly to see that. So we hire really experienced individuals. They've often got 8 years plus of experience, and they sometimes come from being qualified social workers, qualified nurses, probation background, working on the front line, and we want them to carry on working on the front line. They don't come to us for an easy life. It's not a step down. It's very, very much frontline work, and they know that they're going to carry on that frontline work. They've often got a little bit of annoyance with the system, so they've worked in systems where they've wanted to engage, or they've wanted to take a next step, or they've had an idea, and there's been barrier after barrier after barrier, and we give them a little bit of freedom with some clinical governance to keep them safe and keep us safe, keep the patient safe, to say, actually, you've got a bit more freedom. You can bend the rules a little bit, and you can do something that maybe another healthcare worker wouldn't be able to do, as long as we can keep you safe and it's productive and it's a therapeutic relationship. We give them mandatory training, they have ongoing clinical governance, and they have safeguarding level 3 as a baseline. We have lots of teaching sessions for all of our practitioners, and because of their wealth of backgrounds, they all learn from each other essentially. We have a really, really good supervision model that is a 3-monthly rolling programme. And so they have a one-to-one with hub leaders 1 month, then they have a clinical supervision a following month, and then they have a whole hub lead group the following month. And that keeps them safe. The complexity that they hold and that risk that they hold as practitioners is really, really heavy. And when Joan was talking earlier about compassion and about somebody to kind of have that overflow of your bowl, we really need to provide that for our practitioners as well. There was a recent study from the Royal College of GPs that looked at social prescribers and the fact that in the next 12 months, a survey that they'd done said that 1 in 3 of them were going to resign. And the key themes that came from that were around their HR, their supervision, their ability to be integrated within the GP or the service that they were involved in. And that's a really, really scary thought. If we think that 1 in 3 of our social prescribers are going to resign in the next 12 months, we need to make sure that we're supporting them and we're going forward in the right way in terms of the complexity and the risk that we're asking them to hold and carry. We have at Focus Care a raising awareness or a significant event. And that is a way that any practitioner, if they've got worries, concerns, something's gone wrong, they submit that and that gets picked up by senior management. From that, we can see key themes that hopefully we can try and address and change. We can address any issues, and we're really, really keen to learn from anything that's happened as well. It gives a sense of accountability and just keeps that clinical governance in place. So we are currently, across Greater Manchester, we have 37 Focus Care practitioners and we have 3 Focus Care assistants. We have 2 Focus Care practitioners who are for homeless families, who are over at the back. There's the lovely Angie and Matt. Give us a wave. They are free today to talk to anybody that wants to talk to them about the Focus Care practitioners for homeless families. And that's in a slightly different model as opposed to being based out of GP surgeries. They work alongside Oldham Council and the housing. So a little bit of a different branch that we've got that we've seen some fantastic results. But please go over and speak to them later today and they will fill you in on all of that as well. We have coverage across Oldham, Rochdale, Central Manchester and North Manchester. And in the last year, we've had 3,171 referrals into Focus Care. Of that, they have had 2,313 accepted onto the caseload. So that difference of what's accepted is often either an individual has been able to access a service and they've engaged well and the need isn't there for Focus Care practitioner in terms of complexity, or that case has been referred on to a social prescriber because actually we know that they will engage and it might only have 1 or 2 issues that a social prescriber is able to deal with as opposed to that high level of complexity and disengagement. So how it all fits with primary care and PCNs and all of the lovely acronyms. So my background is secondary and tertiary care, and the NHS just love letters, don't they? They love making it really difficult for anyone that's outside of our world to find it really difficult to understand what everything is. And I love that primary care is no different. So our practitioners sit under the R's role and they sit under the social prescribing band 5 that we claim, and we're really, really fortunate as a organisation to have philanthropic funding from the Oglesby Charitable Trust that enables us to employ our practitioners at a higher level, that have got that higher level of experience and hold that risk as well. And so we employ them at a band 6 level and we do that top-up funding. That is something that hopefully going forward we can show a model that actually we need to make this go forward nationally, that it is at a band 6 level and that we can demonstrate that importance of it being that complexity. The IIF funding for the social prescribing referrals, obviously every PCN has to now hit the target for. Focused care does come under that IIF social prescribing code, and our practitioners can put that code onto EMIS as well for the patients that they deal with. So looking at how it actually matters for you as a practice, primary, secondary, tertiary care, the reduction in inappropriate A&E attendances has been shown to be absolutely huge from all of the work that we've done and the engagement that we've had with our patients. And then these are some of the things that have come from individuals that we've worked with that I think, you know, when it comes back down to that person level of the individuals that we deal with, these are the things that they said that just mean the world to the practitioners and to us as an organisation, that you know that you've made difference after difference to an individual or a family. So going forward, our future planning, we currently are being independently evaluated by Cambridge University to give us some quantitative data on what we're doing. We know that it's fantastic, and we want that to be shown essentially in something that we can really demonstrate and shout about. We want to continue to give high quality care and service delivery in the areas that we're already in, and continue to build those links around Greater Manchester as well. There is some work going on around homeless family, focused care practitioner growth, which we can speak to Angie and Matt about. I'm sure they'll fill you in on all of that. And also potential growth along the M62 corridor when we look at deprivation health and what we can potentially start to make a difference for. If we've got the model right in Greater Manchester, it would be lovely to see that replicated in other cities in the north as well. Any questions from anybody? This is where you all sit silently and don't give me a grilling. If there's no questions, I think my leave-in point would just be that if you've got practitioners that work with you, embrace them in your practice and care for them, because they want to make a difference to your patients and to you as healthcare professionals. So really, really do embrace them, look after them and make them part of your practice, because you will absolutely feel the benefit of it. Thank you very much.